You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, this is Dr. William E. Morgan, president of Parker University, and this is Clinical Rounds. And today I have a very special guest, Dr. Octavio Choi. Dr. Choi, thank you for joining us today.
Absolutely, pleasure to be here.
So can you tell us a little bit about yourself and your background?
Yes, so I am a forensic neuropsychiatrist and an interventional psychiatrist. So I do a lot of different things. The forensic neuropsychiatry is about me participating in legal cases that involve neuroimaging and other types of neuroscience information to help the courts determine whether, for example, offenders might be considered insane due to a brain disorder. And the other half of my life is clinical, where I work in a TMS clinic, and TMS is Transcranial Magnetic Stimulation. It's one of the tools we now have to non-invasively neuromodulate the brain and treat all sorts of disorders, primarily depression at this point, but with neuromodulation, you just need to find the brain target and the circuit responsible for generating an illness, and we can start to knock the brain back into alignment with these tools.
Well, Parker University has 2 TMS units at our Neuroscience Center, Synapse. And it's been, we talked earlier, we don't like to use the word magic, but it's very remarkable response to treatment.
Yes.
And we talked about maladaptive neuroplasticity and how this affects that. Can you talk about that a little bit?
Sure. So TMS is a remarkable tool. It's non-invasive. There's a 1 in 30,000 seizure risk, but otherwise it is completely safe. And it's both the most effective and the fewest side effects of any treatment for depression. And like I said, there's lots of research to look at other conditions that are brain-based. But TMS works on the principle of neuroplasticity. And the way I describe it to patients, it's like physical therapy for the brain. So just like physical therapy tries to isolate a specific muscle group and it works that group hard, makes it stronger, and at a certain point you no longer need the physical therapy because the muscle group is strong enough. In a similar way, for TMS for depression, we identify depression circuits. We apply the TMS to the depression circuit, and then we apply a pulse pattern that enhances positive neuroplasticity, making that circuit stronger over time. And after a certain number of treatments, the circuit is strong enough where you no longer need TMS, and you can just live your life without depression. I would say as well, though, TMS is not a cure because just like with PT, once you work out the muscle, if you stop doing PT, it'll be good for a while, but it might atrophy again. You might need PT again. TMS will also, it can build up that brain circuit, but often you need retreatment 6 or 12 months down the line.
Now, we see a lot of people with different maladies, but so our neuroscientists are actually stacking treatments. That opens the door, like if you said 30 minutes, but I heard 3 hours too. What do you do in that 30 minutes afterwards? And we could do, people who may not be able to handle counseling now can handle counseling better. But for us, we would have physical rehab that we do during that particular period of that window where they're.
Yeah.
How would you say it? It dampens the resistance. What does it do?
Yeah. So first of all, I'll say that the treatment protocols are constantly evolving, and the treatments used to be 30 minutes long, and now they're only 3 minutes long. So it's hard to fit in with a 3-minute treatment. It would be hard to fit in lots of other things at the same time. But in general, TMS is so safe that it works excellently in combination with other therapies. So I would say, TMS it's very pro-social. It plays really well with other types of therapies. So I would say so some people still do 30-minute long sessions of TMS. You can integrate therapy into that because
while they're on it,
you're getting zapped by the machine, but there are these long pauses in between the zap. You get a train of pulses and then there's a long pause. So there's a lot of doctors that are actually trying to do therapy in those pauses between the zaps. So that's one example.
Wow. So you also use DTI and functional MRs to find out different spots that you use that to target your TMS machines. Is that true?
Well, yeah. So in the clinic, we don't do that because insurance doesn't pay for it. But at the research level, we do. So in the clinic, we choose a spot for depression over the left dorsolateral prefrontal cortex. We know from a population statistical average that this is the right spot for most people. It hooks up to a depression circuit that hits area 25, which is that deep area of the brain that all other people neurosurgeons have been putting electrodes in. Now we don't need to put electrodes into that area, but we can zap it with a circuit that connects to that area. And so in the clinic, we just use a spot, we use actually an electrode spot called F3, which generally corresponds at the population level to the right spot. But in the research lab, you can do super cool things, and they can use precision neuroimaging to map out these circuits so you can hit the exact right spot every single time.
That's fantastic. Now you're psychiatrist, so we've had people with hypoxic brain injuries that we hit the motor cortex, and people with spasticity,
Yes.
and it loosens up.
That's right.
Temporarily, but it's
That's
pretty
right.
amazing.
That's right. So in terms of the mechanism of action of TMS, there's actually two different ones. One is short term, and I think that's what you're seeing, and one is longer term. So the short term is that if you zap the brain and you choose the pulse pattern, you can either make the brain temporarily more excitable or less excitable. And I think that's what's happening with your patients. For a few hours after the treatment, your brain is in a different state where it's either more excitable or less excitable, and you can choose the location where that happens to treat whatever illness you're trying to treat.
Well, we're certainly going to be watching your research to find out what happens, because what can we do? Let's say we do a protocol of treatments, and then we know it's going to last for 6 to 9 months.
Yeah.
What can we do to maybe prolong that? What other adjunct therapies can we do?
Yeah.
Nutritionally, cognitively, different things that you may see at our Synapse Center when you go over there.
Yeah.
So, and you also talked about maladaptive neuroplasticity. Most of us think about neuroplasticity as being positive.
Yes.
You read, learn things, but chronic pain syndromes, chronic regional pain syndrome is an example of maladaptive neuroplasticity. What other maladaptive neuroplasticities do you see?
Well, in general, neuroplasticity is just a fancy way of saying your brain changes. So if you're, for various disease conditions, if you're stuck in a certain let's say brain state, then that is maladaptive neuroplasticity. So depending on what the condition is, there might be different circuits involved. What the TMS can do is, TMS works on neuroplasticity. So short term, it temporarily excites or suppresses cortical tissue. But long term, what it's doing with those zaps is it's building up, it makes the circuit fire. And so as that circuit fires, we can either apply pulse patterns that make that circuit stronger or make it weaker. So for the case for chronic pain, for instance, we talked about certain circuits involved in rumination, like critical rumination, being overly active. So in theory, what we want to do is identify the brain targets associated with that circuit, and then apply the pulse pattern to weaken that circuit. And we can start doing that. That's what the research studies are about.
And you also touched on lightly the dampening effects of the descending pathway and how that can dampen the effects of pain. What actually happens with that?
Well, I think it's complicated, but we know the opioid system is really heavily involved in that descending pathway. And so opioids, has multiple functions that work at multiple areas. But one of the main areas, sites for opioid action, is the periaqueductal gray, which is part of this descending system. We know that when opioids bind to that in that system, it enhances that descending pain dampening signal.
So how as chiropractors, we're interested in this, is there's certain conditions that when we do our adjustment, it's a kind of a reflex reactivation, and there's cord reflexes that we're interested in affecting. Like one thing we see is certain muscles atrophy after a back injury, multifidus muscles. And there's a reflex inhibition that with the adjustment, there's a rapid stretching of those muscle spindle fibers, and it reactivates those muscles. So we're really interested in how can we affect the descending pathway that inhibits pain. And that's one of the things that neurologically we would really like to uncover one day. But I'm talking about
one of the things about about TMS that's a limiting factor is that the magnetic field is generated by the coil put on top on your scalp, and the magnetic field drops off with distance. So to get to these deep areas like the periaqueductal gray, it's pretty tough to do it with TMS. But this is where the next generation of neuromodulation is going to be focused ultrasound. So that's where you have like the gamma knife principle, where you have multiple ultrasound beams all converging at a certain location, and so that can hit very deep areas super precisely. I think that's where, I think that's going to be able to hit the periaqueductal gray, for instance, and enhance the neuroplasticity of that circuit.
So one of the things we worry about, because we've used therapeutic ultrasound, is cavitation of nervous tissue. So by having a reduced amount, first thing when I hear ultrasound and brain tissue, I'm thinking of brain damage and cavitation, but you're able to have small micro doses, but it all converges at an exact point to create heat.
So that's how the ablation happens. So these focused ultrasound machines currently are FDA approved to use high levels of ultrasound to create heat, which then actually can knock off little bits of nervous tissue. So that's how it's being used to treat essential tremor, which can be localized often to like a rice grain size of tissue. And instead of going under the knife and drilling a hole, you can have focused ultrasound beams heat up that tiny little area and just ablate that tiny area. And that happens with thermogenesis. It happens with cavitation, which is the formation of little air bubbles that the heat induces. But there is low intensity focused ultrasound, LIFU, which you can Google, low intensity focused ultrasound, which there's been a slew of studies showing it's ultra safe. Actually, the powers used are less than diagnostic ultrasound. So you think about how safe diagnostic ultrasound is, we use it in babies. The levels of power that we're talking about with the low intensity focused ultrasound is like on the same level as diagnostic ultrasound.
That makes me feel a little bit better about using that.
So right now it's research based, and there's a ton. So that's what all the animal studies right now are establishing. We need to make sure it's super duper safe, obviously, before we do it in humans. But it's thumbs up. It's looking really good.
So you're talking about intention tremors in certain aspects of the brain that you go in. They either put an electrode in, stimulate it, ultrasound. Do they use gamma knife now for that, or?
Yeah, well, that's what the essential tremor treatment is. So they don't use radiation like traditional gamma knife is radiation, and they may or may not. I don't know, but I do know for a fact that one of the few FDA-approved uses for focused ultrasound is for the essential tremor.
Wow, this is fantastic. It's so interesting where we're going with this. Now, what do you see the future going with TMS and the combination of these advanced imageries and TMS and what could we expect in the future?
Yeah, there is no limit. It's like, what's the limit to a computer? It's like once we start, we view the brain as a complicated organic computer, right? And for the longest time, we could only read out information from that computer, either structural images or functional activation images. But now we have the ability to start writing into that computer and actually to neuromodulate it. So anything that happens in your brain, we can now neuromodulate. So when you think about that, the future of that might be like LASIK for brain diseases, which is like, LASIK,
oh my goodness, yes.
Right? Like your cornea is all misshapen, right? And so you go in, the laser kind of automatically bounces lasers all off your eye, and then shapes your cornea to knock everything back into alignment. I think that's the future of psychiatry and neurology, where we're going to take patients in, we're going to scan their brains, and we're going to find overactive and underactive areas. Then we'll use focused ultrasound, for instance, and we'll kind of start to knock those areas back into alignment. So it'll be like LASIK, I think.
Wow. Well, what we talked about earlier about, you know about this, I know about this, but it's the best kept secret in psychiatry.
That's right.
We're trying to get referrals from psychiatrists for treating primary depression, which Medicare will pay for if you failed 2 rounds of drug therapy.
Yes.
And you have a diagnosis of primary depression, it'll pay for it.
Generally, that's true.
So we're trying to get the word out. How is the word getting out in psychiatry, your profession?
I mean, to know TMS is to love it. So basically, you just need to tell as many people about it as possible. I believe that TMS is both the most effective treatment for depression and the fewest side effect burden. And it's non-medication, which is very appealing to a lot of people. It also plays really well with medication, so it can augment the effect of medications. So basically, the only barrier to TMS adoption at this point, it's not efficacy, it's not safety, it's just knowledge. So the more people that know about TMS, tell everyone you know about TMS. TMS is awesome.
I agree. One technical question to let you go is will TMS, like if you have somebody who gets frustrated and angry, really emotional, can you affect the amygdala of the brain with that, or is it too deep?
The amygdala is too deep a structure to hit with TMS. I think in the future, focused ultrasound might be a way to do that. But what TMS can do is it can enhance the activity of the frontal lobes. So if that person is angry and also has depression, I'd say go for a round of depression treatment with TMS, because not only does it improve that circuit, right, with neuroplasticity, it also enhances the activity of the frontal lobes, so better impulse control, and so that should result in less observable anger behaviors.
Well, thank you so much for joining us today. It's been a blessing.
My pleasure.
Would you mind sharing your contact information?
Absolutely, yeah. So my Stanford email address, email is a good way to contact me. It's ochoi, O-C-H-O-I, @stanford.edu.
Thank you for joining us. You've been listening to Octavio Choi, and this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.